I want to shift gears a little bit. I'm going to ask Howard about oncolytic virus therapy.
Yeah, so for something completely different.
Yeah.
So the concept of oncolytic viruses is that certain viruses have innate properties or can be engineered to selectively replicate in cancer cells. And so the first such virus achieved FDA approval in October of 2015. This was using a herpes simplex type 1 virus, which causes the typical fever blister. The virus has been engineered so the neurovirulence factors are removed, and it also encodes GM-CSF to help to generate an immune response. And so this is actually given directly into the tumor. So the way we do this is patients who have accessible lesions come in the office. We actually measure the size of the tumor on a given day, and we can inject up to 4 cc's of this at any given time. We start with a low dose and allow the seronegative patients to convert, and then 3 weeks later we give a higher dose every 2 weeks. And in what was really the first prospective randomized phase 3 study, the treatment it's called telimagene laherparepvec, or TVEC is the easier pronunciation, did show an improvement in both durable and objective response rates. There was also improvement in progression-free survival and overall survival, although the overall survival benefit didn't reach statistical significance. Nonetheless, a lot of patients experienced significant improvements, and I think that oncolytic viruses have a lot of potential for taking T-cell poor tumors and bring in T cells and make them T-cell rich. And so I think that obviously gets us into combining it with other things that can expand T cells, and many of those combination studies are underway, and we anticipate reporting out on some of those very soon with some pretty interesting results. In terms of toxicities, we see very little. So there's some low-grade fever and chills, and we've been seeing sometimes some injection site reactions. It's usually pretty well tolerated with some Tylenol on the day of the injections. So it's another approach. It's been particularly useful in elderly patients, patients who may have other comorbid conditions so they can't really tolerate some of the more extensive therapies. Interestingly, in the phase 3 study, we close to an 11% complete response rate. So even visceral lesions, other lesions that weren't injected did go away. So it adds another therapeutic option, and I think future studies are going to be doing these combinations and then extending this into other types of cancer.
And there's some efforts in bladder cancer, correct?
There are. Actually, there's a replicating adenovirus, CG0070. Same kind of approach. This has a GM-CSF vector that inserted. Interestingly enough, there was a study really just looking at whether the virus got into the tumors and whether there was GM-CSF that was elicited afterwards, that it actually replicated in the bladder. Although it was a study looking at really an analysis of whether it worked or not in terms of GM-CSF, it actually did cause regression of tumor. In fact, substantial regressions, over 40% of now. This is in bladder, non-muscle invasive disease. So this is that space I was talking about before, that BCG unresponsive space where there are no therapies, in which you don't really need a randomized controlled trial. FDA will accept a non-comparative trial, and so that is in study now in the U.S. To see if there's benefit.
And with Atezo being approved in bladder, do you see room for combination therapies down the road?
Oh, I think that's where we're headed. If you take a look at a lot of these tumors, there are a lot of tumors that do not have infiltration, and the question is, how can you provide that impetus, the recognized antigen, one way or another, whether it's injection of a virus. In fact, we're looking at Newcastle virus at our center, or whether it's by radiation therapy. The breast groups are using cryoablation and combining it as well. So yes,